Welcome. This is going to cover the electrocardiogram and some of the basics about the heart rhythm, heart axis, and getting heart rate. So remember, the electrocardiogram is simply the electrical activity of the heart. And if you're lucky enough to have a 12-lead electrocardiogram, you'll actually get 12 views of the heart, 6 limb leads and 6 chest leads for a total of 12 views. So the ones on the right are the chest leads and the ones on the left are the limb leads. Typically in the lab classes that we have, we'll only measure lead 1, lead 2, and lead 3, but these are a pretty good view of the heart. So we don't use those chest leads in lab. Typically we use 4 electrodes, 2 on the arms and 2 on the legs. Recording across the chest from the right arm to the left arm is lead 1. Recording down across the chest to the left from the right arm down to the left leg is lead 2. When we say lead, we don't mean the electrodes, we actually mean the view of the computer, the electrocardiogram. Lead 3 is basically down across the chest down to the right side. So we pretty much have surrounded the heart by looking at lead 1, lead 2, and lead 3. And you might recognize that triangle there. That's basically Einthoven's triangle, which is these 3 famous leads, typical limb leads that we see. Since you're looking at the heart from 3 different computer views, it doesn't surprise you that the tracing or the recording looks slightly different on the electrocardiogram. So lead 1 looks slightly different than lead 2, looks slightly different than lead 3. The other thing to keep in mind is different leads will have different strength of signal. So in this case, lead 2 and 3 have very strong signals, which suggests that the person's heart is either depolarizing down to the right or down to the left. And if you split the difference, it's probably straight down to the floor. Whereas lead 1 has a tinier signal, meaning that their heart's not depolarizing as much straight to the left. Most people's heart will depolarize down and to the left. If the wave of depolarization is moving away from your lead, you'll get a negative deflection, a negative signal. So keep that in mind. When we look at an ECG, the size of the signal kind of depends on the orientation of their heart and the lead that you're using. If we use lead 2, because most people's heart depolarizes down to the left, we can usually see a really nice P wave. We can see the QRS complex. Sometimes you won't see a Q, you won't see an S, but you'll almost always see either an R or an S. And then following that will be the T wave. Sometimes, rarely, you'll see a U wave. Then a flat line until the cycle begins PQRST, PQRST. And around you go, looking at the electrical activity of the heart. One thing to remember is that the electrocardiogram only represents electrical activity. No valves, no contractions, only electrical activity. The P wave is dependent on the atrial cells or atrial myocytes. When they depolarize, causes the P wave. When the ventricular myocytes change their charge from negative to positive, that represents the QRS, ventricular depolarization. When those cells reset their charge on the inside back to negative, you get repolarization, and that represents the T wave. T wave represents ventricular repolarization. So keep that in mind, only electrical activity on the ECG. Now, if you wanted to know, well, where does contraction take place time-wise, you could infer, right, that right after the QRS will be ventricular contraction or ventricular systole. So right after that QRS, the ventricle will contract. That contraction will last till about the T wave, the end of the T wave, mid-T wave. So that would be considered systole. So I've shaded that in yellow. If you wanted to look at the atrial contractions will happen just after the P wave, right? So I'm drawing them smaller because the atria generate less force. If you wanted to see where diastole would be, well, first we'll shade in systole. If you wanted to see diastole, relaxation and filling of the heart, that would be between the T wave and the next cycle beginning. In case of the ventricle, the QRS. So that would be ventricular diastole when filling of the heart occurs. So again, we can't see that on the ECG. We can only infer where those would happen over time. One question that sometimes comes up about why is the QRS and the T wave both positive, or sometimes in some leads both negative? How come they're not in opposite directions, since one represents depolarization and one repolarization? And it's a good question. It's a little hard to explain, but something like this. When the heart depolarizes, the cells depolarize first in the endocardium and then in the epicardium. And so that gives you your QRS, which is an upward deflection in most leads. Repolarization, though, takes place first in the epicardium and then last in the endocardium. So you get a similar electrical vector on the skin surface regardless of whether it's ventricular depolarization or repolarization. They both give you the same deflection. It's kind of hard to understand, but that's the basic premise. And also notice that the depolarization is really fast, whereas the repolarization a little bit more slow. So you get a narrow QRS and a wider T wave. Okay, what about when you're looking at the size of these signals? So if you notice, lead 1 here is not a very strong signal, whereas lead 2 and lead 3 you get really nice high QRSs. That R part of the QRS is a really nice tall positive response. That's suggesting that the computer is getting a very strong signal, which then suggests that your patient's heart is actually generating signal that's moving in the direction of that lead. In this case, in this patient, probably down to the floor, since lead 2 and lead 3, which are down to the right and down to the left, show you a good signal. What about determining heart rate? If you ran your ECG at a typical speed of 25 millimeters per second, you can do a shortcut where you try to determine the amount of time between QRS, between beats, and you can try to get the heart rate. One of the tricks is to simply count the number of large boxes between two successive Rs, between each of the QRS. You can count the number of small boxes and divide that into 300. Again, that magic number 300 only comes from running your ECG at a standard speed. In the case of this ECG, you have a little more than 3 boxes, suggests that their heart rate is probably around 100, maybe a little bit below 100, since it's a little more than 3 boxes. If you've got a calculator, you can actually do this much more accurately by counting the big boxes and small boxes and calculating the time. But most of the time, really fast on a quiz, just divide 300 by the number of large boxes and you'll get the heart rate. So 300 divided by 5, you got a heart rate of 60. All right, the next thing we're going to look at, I wanted to point out that sometimes your your atria, will have a different rate than your ventricles. So do that, you can actually calculate the atrial rate as well. Okay, what about axis of the heart? People are always asking on quizzes or looking at the ECG and trying to figure out their heart's axis of depolarization. So specifically, we're going to look at the axis of depolarization of the ventricle, which is called the QRS axis. But you can actually do the axis for the P, QRS, and the T waves, but we're just going to look at the QRS. So what's the direction of depolarization of our ventricles in our heart? That's the QRS axis. And it's expressed in degrees from 0 to 180, and then negative from minus 150 to minus 30. So most patients, though, their depolarization will pretty much be between 0 and 90 for most of the students and most of the patients that you'll encounter. Okay, again, what does this mean? It's telling us the average direction of depolarization of the ventricles if we're doing the QRS axis. And the way we're going to do that is using the 6 limb leads that we've been talking about. Well, we've been talking about 3 of them anyway. Lead 1, lead 2, and lead 3. And just with those, you can get a pretty good idea of axis, but we're going to use the other limb leads called AVR, AVL, and AVF. Here they are shown with their direction: lead 1, lead 2, lead 3 down to the right. We also have now AVF, AVR, and AVL. It's going to give you a better, more accurate estimation of axis by using all 6 leads. So AVR is up to the right of your patient and AVL is up to the left. AVF is down to the floor, but this gives you a nice 360-degree frontal view of the electrical activity of your patient's heart. Right? And again, we're assigning degrees, and we'll try to get as specific as we can, but even if you could just estimate 30 to 60 degrees axis, it'll give you an idea if your patient's in the normal range or outside the expected normal range. So again, this is going to rely on you being able to look at your electrocardiogram and pick out those really tall peaked QRS waves versus are your QRS inverted. So remember, if they're inverted, it means the heart's electrical activity is going opposite of the lead view. So in this case, if our heart was depolarizing up, AVR would be positive and lead 2 or lead 1 would be negative. So let's look at this in a little more detail. If your heart was depolarizing down towards the floor, you would expect AVF to have a high peaked QRS. If it was moving away from AVF, going up towards your head, it would be negative. All right, so there's this web app that allows you to look at this, and you can control the patient's electrical depolarization axis. So you can actually say, okay, I want a patient whose heart's depolarizing down or up, and then you can look at the way the ECG changes. So let's say our patient's heart is depolarizing down to the left like most people. You would expect lead 2 to have a very high peak. You would expect lead 2 to have a really strong signal. Now we're only showing the QRS signals here on this little chart, but you can see lead 1, lead 2, AVR, AVL, and AVF. Now lead 2 has a very strong signal, which we'd expect if the heart's depolarization is moving at our lead. We look at AVR, which is the opposite, right? AVR looks up and to the right, and we see a negative mirror image because the patient's heart is depolarizing away from AVR. We can also see something interesting if we look at AVL. The QRS has an equal R and S. It's called equiphasic, meaning the positive and the negative shape match, and some textbooks call that biphasic or isoelectric. We'll call it equiphasic. Why is that interesting? Well, if you can find an equiphasic limb lead, it means that the heart is moving, the heart's electrical activity is moving perpendicular to AVL, which would be either lead 2 at 60 degrees or above AVR at a minus 120 degrees. Well, we can't be moving up towards AVR because that signal is negative, inverted. So we must be moving, as we already know, down towards lead 2. So these two signals, lead 2 and AVL, suggest that our patient's heart is depolarizing at 60 degrees, and we would report their axis at 60 degrees, down and to the left. Again, we can simply analyze the 6 limb leads and try to figure out if it's unknown, right? Right now, we know the patient's axis of depolarization because we're setting it. Here, I'm setting it to 0 degrees. 0 degrees is in the direction of lead 1. So now, as we expect, if we set it to 0 degrees, our patient's heart is depolarizing straight over to the left. And so we have tall, tall peaks in lead 1. We also notice, right, that we have negative QRSs in AVR and lead 3, which are on the right side. You can also use that equiphasic trick by looking and finding an equiphasic lead, in this case AVF. That tells you that either the axis of depolarization is either 180 degrees perpendicular to AVF or towards 0 degrees in lead 1 perpendicular to AVF. And again, we know it's towards lead 1 because we see a great deflection, a very strong deflection in lead 1. So basically you can use these limb leads to figure out the axis of depolarization simply by analyzing which get the strong positive signal, which get a strong negative signal, and also if you can find an equiphasic lead. Now I've purposely stuck this one in between a couple of leads because that's more normal, and in this case we should see a strong signal in lead 3 and AVF, which we do. And we don't see an equiphasic lead, but we see one that's kinda equiphasic, AVR. So remember, we should be perpendicular to AVR. If we look perpendicular to AVR, that leaves us with a couple choices, lead 3 or maybe minus 60 way up at the top. but we know we're going at lead 3. So this is a pretty good clue that yes, we are probably somewhere between lead 3 and AVF. A final example here is to have a patient with an axis at 30 degrees. Again, you would expect a great signal in lead 1 and lead 2. And then in this case, you have an equiphasic lead 3 perpendicular to that is right between lead 1 and lead 2 at 30 degrees. So these are examples of what you would expect for the limb leads when your patient's heart axis is in the various directions. But I wanted to show you on a real example where you don't know what their axis is. So again, the first thing you should do when you're presented with an ECG and you want to do axis is try to find the highest peaks. Try to find the most positive QRS leads. And in this case, it's pretty clear lead 1 is the best response. So we're probably going towards the left side. But we also want to look at the case lead 2. Lead 2 is really strong. So okay, then lead 2, then we would be in this half of the 360 degrees. And if we look where they overlap, we've kind of cut down our axis to somewhere between -30 and 90 degrees. So that's a pretty big area, but at least we know we're in the normal range. This is considered normal axis. But let's use the trick where we're trying to find an equiphasic lead. It looks like lead 3 is not quite equiphasic, but pretty equal. It looks like the R is a little smaller than the S. But if we go perpendicular to lead 3, that puts us at either 30 degrees or -150 degrees. If we look at AVR, that's negative, so we can't be over there. So that puts us right between lead 1 and lead 2 at about 30 degrees. Probably we're not quite there, but right at around 30 degrees axis. So for this patient, I would report their axis at approximately 30 degrees. And we can use the other leads just to make sure it's consistent with what we think. Again, this is the QRS axis. Let's try another example. Again, the first thing you should do when presented with a patient, first, if it's a 12 lead, ignore the chest leads unless you want to see if they're having a heart attack or something like that. So we'll find the biggest peaks in this case. The biggest peaks seem to be in lead 2 and lead 3. So again, and also AVF. So these are all really nice tall QRS peaks. So that means we're either going down to the left, down to the right, or down to the floor. And so the most consistent thing would be like probably we're right in between lead 1 and lead 2, and we're down at the floor at AVF, which would be 90 degrees. But again, let's use our equiphasic trick, which it seems like lead 1 is almost equiphasic. If you counted the little boxes, it's like 4 up and 3 down. But that would put us perpendicular to lead 1. Lead 1 perpendicular is either straight up or straight down, which again confirms we're at 90 degrees. And if you look on this 12 lead ECG, they actually report the actual value for QRS axis, and it's actually given at 88 degrees. So we did a pretty good job. So pretty close. Again, we're just using the 6 leads to try to get it as close as we can. Okay, if you look at a 12 lead ECG, you'll notice those chest leads. Sometimes they're called precordial leads. What are those for? And those are typically used to get a better view of the heart, either on the right heart, the right ventricle, or the left heart, and even sometimes the bundle branches. So this will tell you a little more information. So when you become an ECG expert, you can tell things related to the atria, the ventricles, by using these 6 leads and these 6 views, which sort of shift from the right side of the heart around to the left side of the heart. So one of the things you might see in some of the 12 lead ECG might be a heart attack. A heart attack is kind of interesting because a group of cells aren't repolarizing and depolarizing correctly, and it seems to affect the ST segment. The ST segment is that little short flat line, usually between the end of the QRS and the beginning of the T. Well, in people with a heart attack, because of that electrical disturbance in those damaged cells, the ST segment can elevate, and that's called ST segment elevation, or sometimes STEMI, and that can indicate a heart attack. What about rhythm, right? So again, we expect in most of our ECGs, especially students in class, to see nice normal rhythm, sinus rhythm, SA node, atria, PQRST. But look at this ECG here. You can see the atria are actually depolarizing randomly, chaotically, and that causes this wavy baseline, almost looks like noise. And then the little ventricular myocytes follow at almost a random rate as they're bombarded with signals from the AV node. And so you get this rhythm that's typical of atrial fibrillation, where you get fairly normal looking QRS, but because the atria are contracting irregularly, you get an irregular rhythm. Again, we always expect to see a PQRST. What if you see just noise like this? Well, if your ECG is hooked up right, that's probably a sign that you have ventricular fibrillation where none of the cells are depolarizing in a coordinated manner. So you might need to shock the heart to try to bring it back to normal sinus rhythm. So that would be an example where you would use a defibrillator to try to shock the heart. Sometimes you might see an arrhythmia where you see a really irregular pattern of a bunch of P waves followed by a QRS, but it's not every P wave followed by a QRS. In that case, sometimes the heart is not sending the signals from the atria to the ventricles via the AV node or atrioventricular node. So that can be some type of heart block that involves the connection between the ventricles and the atria. I just wanted to point out that normally you'll call a normal rhythm normal sinus rhythm or sinus rhythm. And then if the heart is beating too slow, but it's the SA node that's pacing it, that would be sinus bradycardia. A slow heart rate, but still physiologic, regulated by the SA node. Again, you'd see those QRSs spreading out. You could do your trick with determining heart rate. If you have sinus tachycardia, that would suggest that the SA node again is causing a physiological increase in heart rate. Sometimes bradycardia and tachycardia can be due to problems with the SA node. In that case, you would have some other type of rhythm like ventricular tachycardia, right, or supraventricular tachycardia, where the SA node's not pacing the heart and it's too fast or too slow. Just one more thing that we commonly see in class are these random ventricular beats, and so basically depolarizations. This is an early depolarization by a group of ventricular myocytes that causes the ventricles to have an early excitation, and sometimes you'll hear that called a premature ventricular contraction, in quotes, because we can't see the contraction. But that early signal in the ventricles basically paces the heart before the SA node, and so you get an early beat, and then sometimes you'll get a pause before the next beat. So that ventricle is actually pacing itself just for one little beat in there, and then the SA node takes over again, and you get a regular, back to a regular electrical activity. If that causes a pause and your heart fills with extra blood, sometimes you'll feel a little thump in your chest, and patients will call that a palpitation or a skipped beat. All right, that's your basic introduction to ECGs, and I will see you